Thanks everyone for joining this call. We're going to have an update on the right to health work that we have been supporting with SATHI in the aftermath of the pandemic. It has become a combination of post-pandemic recovery of health systems, as well as how to advocate for people's right to health, given the scenario of the pandemic, the changes in the health system that came after, the opportunities for people's participation through government schemes like Jan Arogya Samiti, Mahila Arogya Samiti, etc. When we have talked about the long history and progress of this work in Maharashtra, the question has always been, well, how about extending to other states? And the process of extending to Bihar actually started prior to the pandemic, after the Aid India conference in Hyderabad. Kamaini and Bhau, I believe, from SATHI discussed the possibility of extending this to Bihar, and we got that work going. Obviously, the pandemic affected many things in many ways, but now what's exciting is that that the work has continued, is regrouping, and there's a plan to strengthen it going forward. So both in Maharashtra and Bihar, we have a combination of exciting progress and plans being made, as well as of certain setbacks and right to health. How do we keep our eyes on the prize of right to health for all, quality health, access to everyone, but right. So with that, I will.
So Jai Bhim, Satrangi Salam, Inkilab Zindabad to all of you. I go by Show.
Sure.
And I have been working as a whole-timer for the last 10 years or so now at the JJSS, Bihar. JJSS or Jan Jagran Shakti Sangathan is a trade union of landless laborers, marginal farmers, and youth, rural youth especially. And we operate out of 4-5 districts in northern and northeastern Bihar primarily. And as part of the union for the last around 1 year, I would say, we've been looking at health in bits and pieces for a while now as an organization. I'm sorry. But for the past 1.5 years, we've been putting in some serious thought and trying to build a solid team that can focus on health rights and building some kind of a community health program as part of the union within the communities that we work with, which are primarily rural, agricultural, working class communities comprising mostly of Dalit, Madalit, Bahujan, and some Adivasi groups. Largely women, because the men migrate looking for work for most of the year, but also with men and with young people and with children too, like I said. So that's it for now in terms of introduction, and maybe we can talk more as the session progresses.
Sure. Thank you, Sho. Ashish?
Hello, everyone. I am Ashish, and I also work with JJSS. Shohini has already introduced JJSS a bit, so I don't need to elaborate. And I have been with JJSS for about 15 years now. And I don't need to talk much because most of the work, the health work that is going on in JJSS is now taken care of by a team. Shohini is coordinating that team. I am here just to give perspective from JJSS and fill in wherever possible. Thank you.
Thank you, Ashish. So now over to you, Dhananjay.
Namaste, Salam, Jai Bhim. I am Dr. Dhananjay. Currently, I'm a director of SATHI. SATHI, as you know, is a support for advocacy and training to health initiative. We are a Pune-based organization, and I'm really looking forward to this interesting conversation ahead. I'm struggling to really make a sequence of how do I present a complex picture of Bihar in a chronological order, because what I have witnessed with Shohini is entirely different than what we have been doing in the state of Maharashtra. Of course, this is not the first time that I have been to Bihar, but what I saw in Araria was quite unique. no amount is actually superlative to, uh, no words can actually describe in the crisis that we have been witnessing, sort of a public health crisis that we have been witnessing in a couple of parts of India and particularly in Bihar. Going back to the COVID pandemic, I mean, almost there's a global recognition and a lot of documentation has already taken place in terms of how public as well as private health system have failed the poor and marginalized people. And one of the worst affected state was Bihar, actually. And all our NFHS data, NFHS is, as you know, is a survey that is conducted by the Central Public Health Ministry. And it shows that the previous gains regarding immunization, ANC, PNC, all that momentum to an extent was also lost during pandemic, and that recovery is still on in the state of Bihar. Of course, we don't have a data to compare what happened in pandemic because NFHS was conducted immediately after that. But just to give you into the glimpse of the crisis that we are witnessing in Bihar, I'm not specifically commenting on Araria. I'll come to that in a moment. But in terms of immunization, 34% children have missed their immunization during pandemic. So they have not even received a single shot. 53% of the respondents with children between 7 to 36 months did not receive any form of a take-home ration, what we call as a THR. That's actually I will call is as a root reason for, to an extent, a nutritional crisis in some of these areas. Coming to specifically Katihar, Araria, and Saharsha, these are the three districts from where we had this women activist associated with JJSS who came for training, which was conducted by my colleagues. So women who are aged between 20 to 25 and married before age of 18. So the percentage is 49% women in Katihar, 43% in Araria, and 43% women in Saharsha are married before 18 years of age. Now, this is immediately after the pandemic. We have to really compare this with the previous set of data. And what we are looking at is actually a chain of causal reasons which will lead to a further sort of a cycle of malnutrition, early birth, and so on and so forth, and anemia in women. 49% children between 6 to 59 months, I mean 5 years, are stunted. Now this is actually comparable to sub-Saharan Africa. This is the level of stuntedness that we are witnessing. And state has only 0.06 hospital beds per 1,000 people, which is far below the WHO norm, because WHO norm says 3.5 beds per 1,000 population. In Bihar, it is actually 0.06%. I mean, this is a grim picture. And I'll start by saying that the current crisis of public health system that we are witnessing in Bihar is deeply intertwined with the historical negligence of public health and nutritional services, because this has not happened over the last 10 years. So it's a history of around 30, 40 years. And what we are witnessing now is the most rabid symptoms of how a chronic neglect of some of these essential services will manifest at the level of community. So that's something that is something we have been witnessing. So during my visit, I had an opportunity to meet some of these women who attended our trainings. We had a good interaction with them. I had a long interaction with Sho and one of the colleagues from JJSS, Ashish. And we also visited CSC in
Barari.
Barari, sorry.
In Katihar.
So and it was in a way a microcosm of what might be there in the other public health institutions in these districts. So obviously the vacant post, non-availability of medicines, problem like corruption, denial of services, behavior of the public health functionaries, etc. in the public health system. These are some of the problems which are not per se unique to Bihar, because this exists even in other states. But the scale that I have witnessed is astronomical. I mean, I have never seen that. For some strange reason, Bihar government has decided to turn their PSCs into CSC without fulfilling even a basic criteria of what is the core minimum requirement for a CSC like institution. So the place where we went to,
Community health center.
sorry.
Community health center.
Community health center. Sorry, this is abbreviation. So if I ever use an abbreviation which is not very clear to everyone, please interrupt. So this community health center, there were only 2 permanent staff, and rest everyone was were contractual workers. In fact, the person that we interacted with has been working on the contractual worker for last 17, 18 years. Now, these are policy decisions which I will say this is a long arc that is required in Bihar where policy advocacy is successful. The day that happens, perhaps the health for all situation in Bihar will be slightly more nearer. But that is something that is very difficult. So in totality, I'll say that key areas that my team, Sho and Ashish, we have identified, and Sho and Ashish might add afterwards, is if I have to outline 3 overarching themes where the work is necessary in Bihar, is first and foremost knowledge, understanding, and awareness. And when I mean knowledge, understanding, and awareness, it should basically start from health literacy and knowing our body. Because that is something which was clearly missing. And part of it is already covered in these 4 or 5 trainings that we had in the current phase of activities. But I think a more in-depth training is perhaps required. So under health literacy and knowing our body, possible sub-themes could be, these are just illustrative ideas, and there's obviously a scope to expand this. By understanding basic anatomy and physiology, menstrual health and hygiene, nutrition and diet for women, common health issues of women, maternal and child health, especially antenatal and postnatal care, importance of skilled birth attendant, mental health awareness, and recognizing danger signs. Second, that as a theme, will be important here is knowing the public health system and functionaries, because that kind of a literacy is required in order to have even some semblance of accountability dialogue. People are simply unaware about who is expected to provide what and when. And that is something I thought is going to be important. And under this theme, that is no public health system and functionaries, possible sub-themes could be health and wellness centers. Now, this health and wellness center, as most of you will probably know, is rebranded by government as Arogya Mandirs. So everything is Mandir nowadays. So that's something that's there. And then community health centers, services expected to provide to be provided by CSCs, roles of key health functionaries. And this could be ASHA, that is accredited social health activists, Anganwadi workers, community health officer, primary health center doctors. One of the other sub-theme that we have identified is probably a corruption that happens at a local level, interaction between ANM, ASHAs, and potential beneficiaries, and identifying issues and addressing the issues of corruption. Regarding and there are two more themes that are important. One is knowing the schemes and scheme incentives. Because some of these schemes are very important for marginalized people. Of course, the money that these schemes provide is may not be sufficient to take care of all the health related crises, but at least it is some sort of a support for deprived community in terms of ensuring that they get the scheme benefit in a form of money or in a form of direct services. So and lastly, very intuitively people know what and why of the scheme. What they lack is negotiating with the system. That is how. And that how thing is very important when it comes down to trainings and really empowering communities to access not just public health services, but also access the schemes. So overarching themes, as I have identified, there are two more, but I think access is going to be the central focus when we plan to develop work in Bihar. The theme two is capacity building for improving access to public health services and nutritional services. So theme one was knowledge, understanding and awareness. Second is capacity building for improving access to public health and nutritional services. And theme three, which in my opinion is aspirational. If this happens, nothing like it. But evolving a system for regular dialogue between community and public health functionaries with Swasthya Sathis, women whom we have trained as facilitators or catalysts. So that's when I say a system, I'll come to that. I have to elaborate a bit on what system for continued interaction would actually entail. And this is largely based on our experience of working in the state of Maharashtra. But coming back to theme two, so capacity building for improving access to public health and nutritional services. The cadre of Swasthya Sathis, I think about 20 to 30 women that we are already training, they will be further capacitated and enabled to facilitate interface between community and public health services. In an operational sense, it will also mean that some of these Swasthya Sathis will be accompanying people when they are approaching public health system, when they ask for a help. Not everyone requires that help, but some of the Swasthya Sathis who have been trained by SATHI and JJSS will have to accompany people in the public health system because essentially they are interlocutors. They are informed people who know how to interact with the system.
Are you specifically talking about Bihar, Swasthya Sathi? Is that
Yes.
because it's
I mean,
not there in Maharashtra, right?
Yes. Swasthya Sathi as a term I have used because there could be other name, but we have to really find out what could be that other name.
But
So
the
Swasthya Sathi
role of this kind of a catalyst or a liaison, that's something that you are initiating in Bihar.
Yeah.
Okay.
So
3 districts.
What will be the scope of this? How many districts or how many villages? I think we are still deliberating on that. Okay. And it will take some, because I have to also share a small note with Ashish and Show about how we look at this model. And second theme in this will be obviously the periodic revisions and refresher trainings that are required for this Swasthya Sathis. And capacity building will also entail a direct interaction with the public health functionaries. There's a passive information dissemination that happens in your training when people like me or Shaku or Bhau speak to Swasthya Sathis about, ASHAs are expected to provide this. It has an impact. But impact becomes far more when Asha herself comes in the meeting and tells what is her work, or ANM directly tells to people or Swasthya Sathis that this is my work. And then that has a different kind of impact compared to, we telling Swasthya Sathis or local community members about who is expected to do what. Now, how much that is feasible in Bihar is something that we will have to discuss. And lastly, community level interactions with women and adults and girls. We do believe that these trained and enabled Swasthya Sathis will be able to work as a resource persons for the local community. And they will be able to have regular dialogue with women and adults and girls regarding the basics of healthcare. Another. Now, uh, coming to sort of a very important and critical issue as far as Bihar is concerned. For any form of a transparency and accountability related discourse, there are some essential precursors. And those precursors mean that basic institutional infrastructure is there. Only then you can talk about transparency and accountability. Second, a degree of a sort of a history is also required in a form where public health system is able to respond to popular demand. That has been the experience in the state of Maharashtra. Now, the problem with the Bihar health system is it's been crushed to this extent that it will not be able to immediately respond, at least in 3 districts, to any form of a confrontational sort of a dialogue we might want to. It can lead to a situation linked dialogue. I mean, if there is a denial of healthcare for, say, patient A, that can happen, but that may not immediately lead to a systemic improvement. It will be case to case kind of a thing, because for system level improvement, entirely different process is required. So Bihar is something about which my very initial thinking says that unlike the state of Maharashtra, the impact of any initiative on accountability or transparency is not going to be very dramatic. Because it's a long arc of change that we have to actually, we are basically dealing with deeply entrenched issues. And that's something that is there. Having said that, I was also very impressed, happy to see that since all the Swasthya Sathis are linked to JJSS, very intuitively they know about rights. So idioms and expression about rights and accountability are not new for them. So that is something which is a very good start, where probably one need not invest a lot of things in terms of really establishing the vocabulary about rights. They know about, because they have worked on the pension, they have worked on the MG and REGA and other things. So that's a good thing. But the health is an entirely different domain. And I was sharing this in Bihar. It's an on and off priority. People do not think about health like what they think about MG, NREGA, or pension. They will think about healthcare institutions only in the circumstances where they need to access health services, and that is something that's a bottleneck.
Thanks for
Yeah.
providing the grim data to start us off with. So do I understand correctly that you have trained or identified some women to be trained as Swasthya Sathis in Bihar through JJSS?
Yeah, these are the women who already attended our 4 or 5 trainings, which happened in this phase. So,
I would like to get a picture of how the Swasthya Sathis and JJS in general, how the community is engaging. Dhananjay left us with a very interesting thought just at the end there, which is that people may not be thinking about health when they're well. This is a very long process. And Sho, why don't you go ahead and talk to us about how some of this work has looked like on the ground?
Okay, great. So, given the kind of statistics and reality that Dr. Dhananjay quoted, you can tell that we are starting from ground zero. And therefore, every little jump that we make, even though in the larger scheme of things it might seem very insignificant or very ordinary, perhaps, for us it's still a huge, huge, and it seems like a huge achievement. And that, I think, gives us the hope to keep carrying on with this project. Otherwise, we'd really sort of get mired with all kinds of doubt and depression and not be able to move ahead. So I think these little jumps help. And of course, our team is wonderful on the ground, like he was also saying. So I think that reinforcement is useful for me as well, that reassurance. health, of course, I mean, not just for Bihar, but I think everywhere, it's not usually a part of your everyday consciousness or conversation. Maybe a little bit in some pockets now, more than ever, but otherwise not so much. To that extent, we actually think that one of the objectives of getting into the health program was to consciously try and include that in our everyday conversation, in our everyday consciousness of what it is like to be a human being, to be a citizen, and to also be a worker, a karyakarta. Because in all these roles, you have to constantly take care of your health, think of your health, negotiate for your health and for others around you. So to that end, we feel that things are slowly but surely changing within the organization. We can sense it. Almost every day, there's a team of 3 who coordinate the health program right now. And Aravinda, you met, of course, Dhananjay ji has also met both of them. But Aravinda, you've also interacted with Chairmanti and Manvi both.
Oh, yes.
And so the 2 of us run the health program. And then there is a larger team of people on the ground. These are village level karyakartas, our health activists, ranging from 20 to 30 across 3 districts. So 30 panchayats, 30 villages in 3 districts. And every day we get calls from at least 2 to 3 people who feel that they don't want to go to the local witch doctor in their village, or who feel that they wish to access government services when it comes to healthcare. And so they get in touch with us so that they have minimum out-of-pocket expenditure, so that they get a rational line of treatment from the best possible and the closest possible person and place. So those have been they might be really small, but to us, these are huge sort of pushes for us in the right direction. I feel you can actually show some of the pictures. The slides that I've sent you are part of a larger presentation that we had prepared. But Aravinda, you promised us that we can do a larger, longer session sometime soon. So I'll save the rest for that.
Definitely.
Sounds good. So I'll save the rest for that. But just to give you an idea of what all we discuss in some of our trainings with Sathi and what has emerged from there, these are some of the parchas that came out of the workshops, and these have been very, very successful because they are visually impactful, and most of our people in our communities haven't had access to school, to literacy, to education, to formal education at least. So yeah, the visual medium really helps. These visual tools really help. The first one that you can see is the free ambulance campaign, which I think has been one of our most successful till date, where 102 is the state helpline number for free ambulance service, and 104 is the complaint number. And using posters, pictures, parchas, which are those pamphlets that we've distributed everywhere, using songs and naras that our didis are very, very well versed with. So for instance, when others were saying ab ki baar Modi Sarkar, we were saying ab ki baar 102 or 104. So it's become part of the conversation. And I had a few videos, and maybe we've sent you one over email and we can do it another time. But these women who have never left their houses, who, who probably haven't even spoken to people, outside of their families, they are dialing these numbers come morning, come afternoon, come night, and they are insisting that they get the ambulance service. The ambulance comes right up to their doorstep for deliveries, for emergencies, for people who are below poverty line. And in case that's not happening, they're complaining on 104, and their complaints are being registered, and then action is being taken, and they're feeling that, and immediately they're getting feedback on that. So that has been very, very encouraging for us. And yeah, initially we used to get a lot of calls that, we are trying 102, but we can't get through, or the person's refusing or is asking for a bribe or something. But nowadays people at the village level are managing just fine. They do it on their own. And mostly in at least 2 of the 3 districts, I think the ambulance drivers also now know that, these are people who are calling from the union and we just have to go because otherwise they are going to create a scene and our jobs might be on the line. So, they are able to get these ambulances right to their doorstep, even at night, without having to pay a single extra paisa. And that, I think, has been very, very useful. Similarly, the 5,000 rupees maternity entitlement for the first child. There have been struggles in the implementation and actual access of the scheme, but at least people have now learned enough about the scheme to be able to demand, ask questions, wonder who's getting in their villages, and keep track of who's getting, how many people are getting or not getting, and so on and so forth. Then the third one is all these really unscientific and sometimes harmful practices that these quacks in the villages practice. So, pani chadhana, which is that, saline water will be injected into your system anytime you're feeling a little weak. And this is the working class that we are talking about, who in all sorts of situations are working on the fields, or engaged in heavy manual labor. And so then, and malnourishment, of course, is so rampant that then they will feel weak, or they will feel faint, dizzy. Sometimes they fall down. And then it is very common practice that, or you get the slightest amount of fever and you have to get up and go to work the next day. So then the easiest thing to do is go to the local quack or call the local quack home, and then he will either inject you with a syringe, or chadhao pani, which is that saline water, and both of these are unnecessary in most situations, highly expensive, and so we're trying to wean people off these kind of practices. And so for dizziness and things like that, we often say you can make your ORS at home, where you can mix sugar and salt in water, in a glass of water, and have that, and you don't need your saline injection or whatever. So that has also been very, very effective. In fact, our health workers started applying it in their lives. They were also initially skeptical, and then once they were convinced that, oh wow, this is fine, and yeah, this is so much better, and it's easily available things at home, then they started advising others and teaching others how to do it. So it's had a ripple effect of sorts. Similarly, injections, the pros and cons of injections. So yeah, these are some of the parchas that came out of the workshops. Thank you, Kirti. And just some pictures of the workshops. They're a lot of fun. We do a lot of physical exercise. We do a lot. Go to the next slide. Just a lot of games and singing and informative sessions. The bottom right picture is one of our young Sathis doing. Yeah, sure. Just a snapshot of the workshops. We've done 5 so far this year. These are some of the village meetings that we do after each workshop. So whatever we learn from the trainings and workshops. It's also important to state here that just like Sathi has been helping us, Dr. Yogesh Jain, Dr. Vasundhara, and their whole team has also been training us. So Mandidi, Jaimanti, and I, we've regularly been accessing those trainings as well. And yeah, both organizations, both processes have been very, very informative and useful for us. And so we learn from these trainings and workshops, and then we take back this knowledge to share in the villages among the communities. And these are some of the pictures of the village meetings that happen, over and above the individual case follow-ups that Dhananjay was mentioning.
Wow. You gave so many disclaimers about how it's, small things seem huge, but I think what you presented is definitely huge. I mean, changing the culture for calling the ambulance, and for the ambulance drivers to go, to realize that you mean business. I think that is huge. I never doubted the potential of your organization to make this work in Bihar, but to see this kind of results, I consider relatively soon, it gives me a lot more excitement about the potential in Bihar. So thank you very much. As promised, we will have a full-length session with you and your team. I'll try to do it in September